ma'am.
Okay. Thanks, Ravana, and thanks once again for inviting me. And good evening, everybody. I am going to present a case of adult onset cyanosis. My patient is a 47 years old female, normotensive, non-diabetic, presented to us with insidious progressive shortness of breath on exertion for 7 years. She had 2 episodes of hemoptysis in last 1 year. On examination, we got pan-digital cyanosis with involvement of both upper limb and lower limb, and which was noticed for last 3 years. And she had grade 2 clubbing for last 3 years. Her oxygen saturation at room temperature was 88%, and she had polycythemia. ECG was normal. X-ray also showed mild cardiomegaly. And when I did the echocardiography, in parasternal long axis, I could see enlarged LA. LV was normal. RV also looked normal. Normal aortic and the mitral valve, there was no MR or ER. In parasternal short axis, I could see pulmonary artery a bit dilated, but there was no abnormality in the flow. There was no evidence of patent ductus arteriosus also. Aortic valve has 3 cusps. I did the 4-chamber where I could see both the atria were enlarged, but the ventricles were normal in size, a good LV systolic function as well as RV systolic function with TAPSE of 2.5 centimeter. She had a trivial mitral regurgitation and some tricuspid valve regurgitation also, and the tear gradient was 56 millimeter of mercury. Her IVC was normal in size, but it was showing sluggish respiratory variation. So she had a pH in the moderate range. We did transesophageal echo also to rule out any possibility of any shunt anywhere. There was no ASD, no PFO we could see. There was no BSD also. And all the pulmonary veins were draining normally. Now, where do we stand now? If we sum up the findings, she presented with dyspnea, hypoxemia, cyanosis, clubbing, unexplained hemoptysis, polycythemia, oxygen saturation was 88%. So all these findings were suggestive of right to left shunt. But in echo, using both transthoracic and transesophageal, we could not get any evidence. Now, what should we do? Is there any other test, any other scope of echo for looking right to left shunt? Yes, there is. It is the saline contrast echocardiography, as Madam also has shown. Though it is known since 1968, but often we forget to use this simple, inexpensive test to rule out right to left shunt. Here we have 5 to 10 ml of saline is mixed with 1 ml of air, and also we draw a small amount of patient's blood and we agitate it in 2 syringes connected through a 3-way stopcock, and then we inject in the peripheral vein rapidly. As we inject, simultaneously we do the echo recording also of multiple cardiac cycles, at least 14 to 15 cycles. Now, normally, as we inject the agitated saline, it goes to the RA first, then to the RV, and then pulmonary artery. And then from pulmonary artery, it goes to the lung. But these bubbles, these air bubbles, cannot cross the pulmonary barrier because the size of the bubbles are bigger than the pulmonary capillaries. So bubbles remain on the right side, they never appear on the left side, and we call it negative contrast echo, and we come to a conclusion that there is no right to left shunt. But if the bubbles appear on the left side of the heart, it indicates that the patient is having right to left shunt. Now let us see what happened in our patient. We injected the saline, it's filling the right side, and then it is coming to the left side. As you can see, 1, 2, 3, 4, on the 5 cardiac cycles, it appears on the left side of the heart. So it indicates that patient is having right to left shunt. Now, is it possible to come to a conclusion at which level the shunt is? Yes. With the time of appearance of the bubbles on the left side, we can locate the right to left shunt. If it appears within one cardiac cycle, it indicates that there is an intracardiac shunt. But if it appears within 3 to 8 cardiac cycles, it indicates that there is an intrapulmonary shunt. So bubbles traveled from RA to RB, then pulmonary artery, and then shunt occurred from the pulmonary artery to the pulmonary vein. And so the bubbles appeared in 3 to 8 within 3 to 8 cardiac cycles. Let us count here. It appeared at around 4 to 5 cardiac cycles. And furthermore, if the bubbles appear in the LV after 4 to 5 cardiac cycles, it is consistent with an intrapulmonary shunt, that is the pulmonary LV that occurs in pulmonary arteriovenous malformation. And depending on the number of bubbles appearing on the left side, we can grade the degree of shunt also. If there is no bubble, then it's grade 0. Obviously, it's grade 0. When there is less than 20 bubbles on the left side, it is called grade 1. And if it is more than 20 bubbles, but incomplete opacification of the LV and LA, it's called grade 2. And with grade 3, there will be complete intense opacification of the left side. Let us have a look at our patient. The bubbles are almost completely opacifying the left side of the heart. So our patient is in grade 3, and these are the patients where we need to go for further investigation like CT pulmonary angio to rule out the pulmonary arteriovenous malformation. So we did a pulmonary CT angiogram where pulmonary arteriovenous malformation was diagnosed. As you can see, this anomalous connection between the pulmonary artery and the pulmonary vein, which was later closed by a coil. So pulmonary arteriovenous malformations are abnormal vascular connections between a pulmonary artery and the pulmonary vein, causing intrapulmonary right to left shunt. And the symptoms typically appear in 4th to 6th decade of life with unexplained dyspnea, hypoxemia, hemoptysis, even stroke or brain abscess. And in these cases, we should not forget about this established, simple, inexpensive, yet surprisingly effective saline contrast study to diagnose it and to confirm the diagnosis of right to left shunt with a very high sensitivity and low risk, and we can even identify the severity of the shunt. Thank you.